Hey, JB and Megan, we're going to give them another 5, 6 minutes and we'll get started. We actually have everything started on time and working properly. So just a few minutes to see if we get any more and we'll get going.
Awesome, thanks.
Hey, and then you guys on Zoom, just make sure that you message me so I get you guys on the roll. You guys out in Zoom land, can you see chapter 13? Is that what you guys are seeing now?
Yep, it's been up for about 10 minutes now.
All right. We will get going as soon as I find my clicker. All right, so chapter 13, did that switch for you guys?
Yeah.
All right, perfect. So we're going to talk on gathering vital signs, the vital signs themselves, and then monitoring devices. This chapter will be kind of the same as some of the others. The hands-on part of it, when it goes through the slides, we're going to jump through them because we're going to do that a lot of that hands-on with you guys in later sessions. So vital signs, it's a major component of the assessment. It will take a few minutes to complete. The only caveat I want to add to that though is if you find something that is life-threatening, we talked about our primary assessment and it's onset. If there's something, a life threat that we find, we're going to stop, we're going to treat it, and then finish our vital signs. Most of your patients though are going to be critical enough that we can have some vital signs measured. It's also how we trend, right? If we're not trending what this patient is doing, we don't know whether our treatments are working or not, or if they're getting better or worse. And then during the secondary assessment, taken during the secondary assessment, we've already hit on that. If there's a life threat, we're going to stop and treat that. So some vital signs. I do like how this words that it's an outward sign of what's going on inside the body. So the ones that the main ones that we're going to look for is pulse, respiration, skin color. The other term you'll hear for skin color is CTC. So color, temperature, and condition. On a lot of the national paperwork, especially for the hands-on, that's how they abbreviate it. Okay. Pupils and then blood pressure. Oxygen saturation, not a vital sign, but often included with consideration of vitals. Why would it not necessarily be a vital sign? We hope we can see it in CTC, right? If they're getting enough in their skin color, if they're oxygenating well enough, their skin color should be the normal pink, warm, and dry. So if it's not, if they're showing some of those others, then it's a sign that we have some vital signs there. Baseline vitals is the first set of vital signs obtained. And usually if we can do it before any treatment, and then we'll talk like when we start giving you guys as patient assist medications, or even when you guys get in the field and can give them without having to have an order for it. If we can get a baseline set of vitals, it just monitors whether our treatment's working or not. Then we're going to repeat vital signs by establishing trends too. And I think it talks about how often here in a minute. Comes back to the sick, not sick. Pulse, it's the palpable heart beat causing the blood to move through the artery waves. Okay, we're going to fill it by occluding the fingertip over the artery where it lies close to the body and crosses the bone. So we've got to have something solid to push it against, which is why on babies and stuff, a lot of the times their little wrists, there's nothing solid enough to push on. Okay. But we can't block it either. So the two things we're looking at though is the rate and quality. On the quality, what we're looking for is it strong? Is it weak? And then regular too. Meaning is that every 6 seconds, are we getting another pulse, or every 2 seconds, or whatever it is. So the pulse, we take it by assessing it, counting it for 30 seconds and multiplying it by 2. I will tell you this, a lot of people, especially when the longer you do this, a lot of us take it for 10 seconds and multiply it by 6. For the national, stick to that 30 and then multiply it by 2. So it's the number of beats per minute is what we're looking at. So that's the other, you'll see that BPM too. So beats per minute is how they'll abbreviate that in different test questions too. Normal rate for an adult at rest is between 60 and 100 beats per minute. So tachy is a rate anything over 100, and Brady is anything over or under 60. When can we start CPR? Danielle, what's the rate we can start CPR at?
That's an excellent question.
Okay, so you can start it at 60. I love the honesty. Thank you. You're good. So you can start it at 60 if they're symptomatic, meaning if we have an unresponsive adult that's laying on the floor and has a pulse rate of below 60, pale, cool, diaphoretic, we can start CPR. Okay. The other thing to consider with these two is age, right? So sometimes teenagers, if they're in the early teens and adolescent stage, will be tachy just at rest because their little hearts, a newborn is beating around 150 to 160. So their heartbeat until they hit full maturity can be a little fast, and it may not necessarily mean anything's wrong. It's just they haven't hit maturity that way yet. Above 150 beats per minute or below is considered a serious finding. The thing that I'm going to throw on this with every one of them is you've got to look at the patient. I mean, those are good guidelines, 50 to 150. Anything outside of that is considered a serious finding. But we could also have somebody that's got a pulse of 52 that's unconscious. It's a serious finding. Okay, we're going to look for other things. Somebody that just got done running may have a beat of over 150 per minute, and we just need to cool them down, take some other things to do. So it's got to be the patient. But you could also have the same thing, somebody that normally runs at 90 that has a pulse of 70, and now they have an altered mental status. So that's the only thing as we talk about vital signs, the caveat that I'll add to it is don't look at the numbers as much as the patient. And then, like I said, during an emergency, between 100 and 140 is normal. I mean, they're anxious, they're excited, and that is a normal finding for us. What are some other normal situations? We talked about running. What are some other situations that might throw the heart rate outside of the normal range? Somebody in Zoom. What's that?
Stress.
Okay, rest will do that. Yeah, there's a lot of us that will, our pulse will go well below 60 when we're resting. How about if they just got in a car wreck and they had adrenaline, right? So any traumas, a lot of the times, if they've been shot or if they've just seen it or whatever, they've been scared, you can see their pulse rate go higher. Rest is usually about the only one that throws it down low if they just got woken up. The other one too, though, is medication. So they can take overdose on medications that control their heart rate and can slow it down too. So two factors in determining pulse quality. We've talked about the rhythm, right? Is it regular? Is there regular intervals between beats, or is it irregular? So we have 2 beats that are the same, and then we have a long pause, and we have 2 beats, and then a long pause, and then 2 beats, okay? On a lot of these, it's just the same. As we talk vitals, you're gonna end up doing 100 vital signs by the time the class is done on different people. We don't care if you know what irregular is, but I just want you guys to know what regular is, so when you feel what an irregular one is, it throws a flag at you. Force. So this is the strong or weak is what we're looking for, or thready is the other term you'll hear when it's weak and thin. And the thing I'll tell you with these two, if it's a thready and weak pulse, you're going to see it in the patient before you ever touch the pulse. They'll be pale, they'll be a little diaphoretic. They'll have some kind of an altered mental status a lot of the times, but you will feel it long before or you'll see it long before you feel it. The strong bounding pulse too, a lot of the times you can see that too, but it's the same thing. If we're that one, the extreme forces, if I can see the jugular pumping every time, I don't want that strong of a pulse. We're going to cause other issues. So you can see that one too once it goes outside of the norm. So let's tie this into some of the anatomy and phys to kind of make this make sense. What part of the heartbeat are you feeling? Is it the ventricles or the atriums pumping? Okay, so you're feeling the ventricles pump. We're feeling when that ventricle squeezes, okay? So some common pulse locations. Radial is by far the most common. It's used in patients 1 year and older, also called the wrist pulse. When you guys document it though, they won't say wrist pulse. It'll always be radial. It's found by placing the 3 fingers of the thumb to the side of the patient's wrist, just above the crease. And we'll go over this. I'll show you a trick you guys can learn and I'll explain it to you, and you guys, hopefully it'll make sense over Zoom. But if you take your hand and put your thumb straight in the air, and they'll feel some tendons that are coming down off your thumb. And then just go to the medial or the lateral, either way you want to put it side of your, and then let go of your wrist or your thumb. And that's where the artery is. It comes right up that set of tendons that go up your hand. Brachial, this is what we're going to use in patients 1 year or older. It's in the upper arm pulse. The thing I'll tell you with this is if you get a really, really chubby baby, a lot of times there's still their armpits fairly thin walled and you can feel it, but it can be a little harder to get used to find it. So there's a picture of it. You're just going to take your 2 fingers, lightly go into their armpit or between their armpit and their elbow and try and find it. It's usually comes right out of their armpit and up. So right across that medial side. We'll go over all this in class too, guys, and show you where to find it and where to play with that. Some other ones that you're going to look for is the carotid. It's felt along the large carotid artery on either side of the neck. It's the same thing when you twist your neck one side or the other. You'll feel that big sternocleidomastoid come down right to where it's against your Adam apple and let it relax. That's where your carotid's easily felt. You can kind of pin it against that big muscle and tendon group there. The other one in CPR that you guys can look at, it doesn't talk about it here, but you can look for a femoral pulse as well. So assessing the pulse, count the pulse for 30 seconds, multiply it by 2. What you'll see, what I hope you guys get comfortable with is holding the pulse. You're going to hold it for 30 seconds, count the pulse for the first 10, then you're going to count the breathing for the next 10, and then still have your hand on that pulse. And as you're counting, that's when we're feeling okay. Is it strong? Is it weak? Is it regular? Try and multitask those 2 things. So hopefully we'll get you to there. But the way we teach it that way is the 30 and then multiply it by 2. If the rate of rhythm or force are not normal, continue with the count for a full 60 seconds. And that is one that I will do. If I have something that's not normal, it doesn't feel right, it's irregular spacing, I get strong ones, then I get weak ones or whatever, then I'm going to do the full 60-second count and try and say, okay, well, every 5th one was really weak, or I had 5 and then I had a long break or whatever. That'll tell me as a paramedic or the advanced or even the hospital that, hey, we need to be getting an EKG or a 12 lead on this patient and see what's going on with their heart. The thing that you guys have to feel, judge the rhythm and force, that's not, that's objective, right? Because what you guys will feel as a strong pulse versus what I say is a strong pulse are not going to be the same. So as we do this, just remember it's judging it. That's why we want you guys to get your hands on 100 different patients and feel it and feel what normal is. And it gives you a baseline, just like the baseline vitals, it gives you a kind of, okay, this is the norm. Respiration is with regard to vital signs, it means the act of moving air in and out, right? We're respirating, but we're not necessarily measuring how well they're ventilating. Two different things. So respiration is air movement in and out, and then ventilating is at the cellular rate. Measurements include both rate and quality. It's the same thing. Are they taking a breath every 6 to 8 seconds? Is it a shallow breath? Is it a normal breath? Is it a deep breath? We're going to check for those things, okay? This slide's out of order. Wait, assessor, oh, no, this is the respiration one too. Assess respiration rate and quality, count for 30 seconds and multiply by 2. So if you guys see how he's placing that, as he's checking that pulse and doing the vital signs, how he tucks it against the patient's chest. The reason he can tuck it on their chest or on their belly, it's easier to count the breaths, because if they're looking at you, they're going to take kind of some shallow breaths and you're not necessarily going to see it very easy. But if you kind of hold the wrist against their belly or chest, when they take a breath, you'll be able to feel it with your hand. I know this one is hard for me, but I just do too much to have it ripped off. But if you guys, when you're running, I would, when I was on call in Wyoming, I would wear a watch with the second hand, just to do vitals and stuff with. So if you're running or know you're on call, I would suggest getting one of those because you'll use it quite a bit. So respiration rates, the number of breaths takes in 1 minute. We've hit that as if the normal, rapid, or shallow. So the normal rate for an adult, you're going to see this on multiple slides and tests and everything as we go. 12 to 20 breaths per minute. So the other part of it too that'll play into it is age, sex, size, physical condition, emotional state will also include fluence breathing rate. So who do you think breathes faster, a male or a female? It's usually a female, but they take shallower, where a male takes less and takes deeper usually. Size too, if they're larger and an obese patient, they're going to have to take more breaths and they're going to have to work harder. Okay. And usually slower, fast respirations may require oxygen, providing ventilations to prevent the patient from going into respiratory failure. We've already talked on that, right? We can breathe with the patient if he's breathing shallow, and then we can breathe in between to try and help him do that. And we'll go over all that in class when we start our hands on. So the 4 categories, we've talked normal. That's just you and I sitting here shallow. I don't know how you can't mimic it very well. The shallow, they're not taking a deep breath. It's just those little short little breaths and it's not going anywhere. A lot of the times if they're breathing shallow, they're also breathing fast. They take really shallow, fast breaths. And it makes the condition worse. So the body tries to up the rate, and the more it ups the rate, the shallower they breathe. So they kind of get a reset. It's counterproductive, but that's the way the body's set up to do it. Labored means that we talk about that as the tripoding position. So if they're leaning over, their hands are on their knees or their elbows are on their knees, leaning over, trying to take a deep breath. That's a tripoded or labored. You'll also, labored and noisy a lot of the times go together. You can have audible wheezing, which means that you can hear it without a stethoscope, but 90% of the patients, if they're leaning over and you take your stethoscope and listen to all 4 quadrants, you're going to find some diminished breath sounds somewhere in there, or they're going to be shallow. Okay. The other part with the labored, when we talk about pediatrics, you're going to see if they're really labored breathing, you're going to see their neck muscles extending and contracting every time they take a breath. And if you can look in between their little ribs, you're going to see those intercostal muscles breathing in and out with them. Okay. If you're seeing a kiddo start to do that, be ready, because they're about ready to go into respiratory failure because they just can't breathe out. They don't have the glucose in stores to keep up with that. If you absorb observe irregular respirations in an unconscious patient, report it and document it. That just comes into part of our assessment too. Really the big one that you'll see with that is a medication overdose of some kind, that you're going to see those irregular respirations, or they're in cardiac arrest and it's the agonal breathing, which technically isn't breathing. When we get into that part of it, if they're agonal breathing, meaning taking those deep, I don't know how else to describe them other than they really are a death gasp. If they're taking those kind of a breath, that is not adequate respiration. Same thing, we're going to count the number of breaths taken over 30 seconds, multiply it by 2. In the documentation, we'll note the rate, quality, and rhythm of the respiration. So skin, CTC, color, temperature, and condition, is going to provide valuable information regarding circulation. And I also like to tie it into respiration if they're not, because those things are tied together. So if they're not getting a good respiration, their skin color is going to look horrible too. So it does both of them, but normally we look at it in regards to pulse. So best places to assess the skin colors in an adult is the nail beds, inside the cheek, and lower eyelids. Do you guys know when they're saying nail beds? Have you guys heard of the cap refill when you read in the book? So you guys have it, it's where you're going to pinch their fingernail between yours and like your thumb and one of your fingers, you're going to pinch it to the fingernail goes white and blanches out. You're going to take your finger off and you want to see it go back to that nice pink color within 3 to 5 seconds. So we're going to check it there. Also, like the cuticles, that's the other word for nail beds, right? It's cuticles right around it. That'll be the first thing that starts to go blue or pale on somebody. It's right in the cuticles. Infants, the palms and soles of their feet. And then in patients with dark skin, so Native Americans, African Americans, anybody that has a darker skin, you're going to see it in their lips and nail beds too. A lot of the times you'll have to do cap refill that way too. So some skin colors though that we're going to talk about. Normal is pale, right? Or abnormal is pale, geez, meaning they're kind of white. They just look like a ghost. I don't know how else to describe them. They definitely go white, and then it goes from that to usually cyanotic and that blue gray. You'll see that in a lot of COPD, CHF patients too. They'll have that cyanotic blue. So like they call them the blue bloaters or the gray guzzlers. Now I can't remember what they call it. It's blue bloaters, because you'll see they bloat out, their skin bloats out, and then they turn blue. Flushed is red, so like we've all seen that when we're running, looks a little bit like a sunburn. It's hot to the touch. Okay. Jaundice is the yellow color. Most of the time you see this, it's either in somebody that's in late stage liver failure or kids. So the UV lights and stuff like that, they'll be underneath that to try and treat for jaundice. So temperature, feel the patient's skin is warm to the back of your hand. I would stay away from pulling your glove back if you can, unless you're going to replace it. And once you get your hand really wet, it's going to be hard. So you can feel just above the wrist. Okay. We're going to see if the skin feels normal, if it's warm. So it's just warm to the touch. Everybody, we've all felt that. If it's hot, cool, or cold. So if we just found somebody that was running or was in an accident, is it going to necessarily be abnormal to have their skin a little on the warm side? So if they were just sitting and been home sitting all day and the chair hadn't felt good and we come in and touch them and they're hot, is that normal? No. Okay. So it's the same thing. I hate as we talk about this, that, oh, this is abnormal. You got to look at the patient on these vital signs. So here's where they're rolling the glove back to fill it. If you can feel just above your wrist, that's the best place. Then you're not pulling that glove back and forth. For children 6 years of old, also do the cap refill. We've already talked on that. And for them, so pediatric is anybody under the age of puberty, right? So just keep in mind, or children under 6. I'll leave it adolescent after that. Even up to the puberty though, guys, check cap refill on them. But if they're under 6, then they want it back in 2 seconds. Because their little heart's pumping away at that rate. A lot of your test questions on the cap refill too will say on an adult is 3 to 5, and then on pediatrics is less than 2. So the pupils, we're going to look at these. So in a dim environment, the pupil is going to dilate. Does dilate mean to open or close? Open. Okay, so it's going to get open. It's going to try and let in as much light as it can to hit the back of the retina, and so that it can stimulate as many nerves to see as well as it could. In a bright environment, it's going to constrict. It's going to try and limit that so it doesn't cause damage to the retina in the back of the eye. So we're going to look for size. We want to make sure they're equality, so that they look at the same, the size of the left is the same as the right. And then reactivity. So the pen light, we'll show you how to do this with the 2. We're going to just run the pen light a straight line across their eyes and see if that pupil, it should react that fast, just with the light going back and forth across it. The pupil should try and constrict. Same thing though, just consider if we pick somebody up and they've been laying out in the hot sun, staring at the hot sun all day, their pupils are going to be constricted. Are they necessarily going to be reactive to light? No. Like, I can't stress this enough. Look at the patient, not the vital signs. We're going to note the baseline size. If you guys cover one eye, shine the light on the other, and repeat with the other. So the pen lights, you guys will see, have on his pointer finger, you can see the sizes. There's little black dots on all of them. It'll tell you millimeters. So when you document it, you can say, okay, it was 15 or 9 or whatever size it was. So a lot of the time, if you can hold that up, so when you're shining it on the pupils, you can take a quick glance at it. It helps that way too. So the constricted pupils on the top, the other word you'll hear for it is pinpoint, and we usually see it in a narcotic or opioid overdose. Makes those pupils go pinpoint. Dilated, a lot of the times when you guys go to the eye doctor, remember you can't drive because they'll dilate your eyes. They're trying to get that open as much so they can see as many of the rods in the back of the eye as they can. And then we can also have unequal pupils. So it can be signs of topical drug use, one placed directly on the eye, such as an eye drop, or a head or eye injury. So if you're seeing this in somebody that's just sitting at home and said, I don't feel good, and you come in and they have unequal pupils, what's our first thought? Medication or a trauma? Probably medication, okay? If you see unequal pupils in a car wreck, where are we going for? Trauma, okay? So where are you going to feel, as you guys palpate, where's usually the place on the skull that they get hit that causes a pupil constriction or eye problem? So it's right on the back. So that your eye nerves, picture them going straight back, and they go back to the back part of your brain. So if they get hit really hard on the back of their head, you can have some vision problems. The other thing you'll see with it, and we'll talk on it, is like raccoon or battle signs to it. So a hit to the back of the head or anything around the eye itself in that occipital orbit can cause some unequal pupils. But then there are the same thing though, asking though, is this normal? Because there are people that have unequal pupils normally, and that's nothing to be alarmed about with them, because they always have it. Blood pressure, we've hit on this one too. The systolic is created when the heart contracts. And diastolic is what remains after the left ventricle relaxes and refills. So normal, I promise you, you will see this one. Systolic, no greater than 120, and diastolic 80. So 120 over 80. Same thing, though, ask the patient, because there's some people that their normal is 90 over 60 and they do just fine. And there's some people that are 140 over 90 that do just fine. Okay. So it's measured with this. I'm not even a blood pressure cuff. I'm not even going to try and murder that word. Okay? That's the fancy word for blood pressure cuff. Okay. Should cover the upper 2/3 of the arm and elbow to the shoulder. So here's your picture of it right there. Okay. We're going to go over how to do this in hand or in class. Like I said, you're going to have to do 100 of them. That being said, if you don't have a blood pressure and stethoscope, you're going to need one when we start the hands on. Okay. We'll go over all of that. So determining blood pressure by palpation, you can position the cuff over the radial pulse, inflate the cuff, obtain a systolic pressure, slowly deflate the cuff. No reading on the radial pulse returns. Oh, so all you're doing is you're going to watch that pressure. That's part of it. That's not. Oh, so this is just if you don't have the stethoscope to listen to it. So if you just have to do it by feel, you can do it that way. We'll go over that part of it. That is not what I was thinking they were meaning with it. I read it closer. Pediatric notes, guys, for infants and children younger than 3, they are difficult to obtain. Try and get a 1-year-old or a 3-year-old to set still for 30 or 40 seconds long enough to take it, right? And also on that note, with the pediatric, anybody under the age of 1, we do not do a blood pressure on. Okay. You're going to have to look at their skin color for that, just because they're little arteries and stuff with our machines, unless you get them on a monitor that has a pediatric cuff. We just don't do a manual. Let me put it that way. We don't do a manual blood pressure cuff on a baby 1 year or younger. So we'll go over the monitors too. Most of the time, those are so much nicer to do them with, but you still got to know how to do the manual part of it. So temperature, it's a range that allows for the chemical reactions at its normal. The core temperature reflects the level of heat inside the trunk. And so when they say trunk, it's like your thorax is what we're after, your thorax and down into your stomach. So, and it does too, guys. It depends on time of day, activity level, age, and where it's measured. Do you guys know what a normal oral temperature should be? 98.6. I have yet to see a 98.6 though, so I've seen them everywhere else, but yes, normal is 98.6. So the electronic thermometer is safer, more hygienic, and it produces a quick reading that way. Any questions thus far on vital signs, guys? So monitoring devices, pulse ox, or also called SpO2, is what we're using to measure amount of oxygen that is carried by hemoglobin. Okay, it's measured with a pulsometer. So there's your pulsometer. So it's going to measure through the finger And if you guys can see, this one has a pulse or SpO2 saturated pulse or saturated oxygen of 98% and a pulse rate of 82. This says generally includes all patients complaining of respiratory problems or other risk of hypoxia. Just do it on every one of them. Okay. Every patient should have a pulse ox. That's an easy one. So some ranges. And the other thing to consider at this too is these are all normal as if you are on the beach in California at sea level. So elevation, the higher in elevation you go, the normals drop. So like for us, our normal around here is 95 to 96. Just because of the elevation and the concentration of oxygen. So, but for normal, 96 to 100, mild hypoxia is 91 to 95. 86 to 90 is severe to moderate, and then severe is 85 or less. And if they're in severe hypoxia, I promise you, you're not going to need the pulse ox to tell you that. So some things that can affect the accuracy of the reading though, shock and hyperthermia. What happens to all the blood in shock? Do you guys remember? Where does it get shunted to? Basically anything but the fingers and toes, okay? It comes back to the core. So it's going to stay in your stomach, your chest, and your brain. Carbon monoxide actually binds to the hemoglobin, has more affinity to it than oxygen. So if you had a house fire or something and you're looking at somebody and they just don't look good, they've been in a lot of smoke, but you put the SpO2 on them and they're meeting at 100, that's probably because they've got 100% carbon monoxide and need some oxygen. Excessive movement, the old ambulances bouncing down the road were really fun to try and get a reading on. The newer ones and the new monitors handle that a lot better. Nail polish though, if you come on a female or male that has really dark nail polish and thick, it's really hard to see through it. The light won't go through it. So you either have to find another one or take a alcohol wipe that's in like your glucometer and try and wipe that polish off. Anemia is another one too, because it affects the hemoglobin. And then hypovolemia, if they, for some reason, we've got low blood pressure, low blood volume, it's the same thing. The body's going to shunt it just like, because it is a form of shock, right? Hypovolemic shock. It's going to shunt all that blood back to the core. Same with hyperthermia and shock. It shunts it all back to the core. Hyperthermia, it's trying to keep the core organs alive. Can you live without fingers and hands? Yeah. Can you live without a heart or lungs? No. So it shunts all that back to those main organs just to try and protect those vital organs. Blood glucometer, it's measured the amount of glucose in the bloodstream and can help identify someone with diabetic emergencies. We'll play with a few of these. So you usually have a lancet, which is the deals on the right. A little blue with a little blue tip and a blue push button. You pull that blue, or you push that blue tip in, and then it pulls out, and then you put that on their finger and click it, and it's a little needle. It's going to cause the finger to bleed and draw some blood. Top right in a little medicine bottle is your test strips, and then the actual glucometer is the bottom left with the two arms on it. You have to use an alcohol wipe. They usually have a Band-Aid tucked in there too, but you're going to take an alcohol wipe, dry the finger really, really well, let it dry, and then you're going to take a blood sugar reading. Permission for medical direction or by local protocols is required to use it. The state of Utah, you can use it without medical direction. But for the purposes of the test, no, you don't have to on this one. So even on the test, you don't have to get permission to use the glucometer. They do have to be calibrated and stored according to the manufacturer's recommendation. we're gonna go all of this. So normal levels, again, guys, it depends on the textbook. You can see anywhere from 60 to 100, 80 to 120. This book's in the middle at 70 to 100. Okay. And it's milligrams per deciliter. That's the normal range that you're looking for. It's the same thing though. If we have a diabetic patient and they're at 90 and they're acting confused, can they have low blood sugar? Yeah, because they may normally run at 300 and now all of a sudden 90 or 100 is a real emergency for them. Okay, so don't not treat them for that just because they're in their normal range. Well, you gotta look at the patient. The other one that's come along now in the last 6 or 8 years, especially, is capnography. So it's the end tidal CO2. The way you'll see it in reports and on your monitors is that EtCO2. Normal levels for it are 35 to 45. When you guys do CPR, it is the first indicator that you have a term that we'll go over a lot more called ROS, return of spontaneous circulation. You're going to see that level go from 25, 30, clear up to 90. Because all of a sudden now the heart's pumping, it's pumping, getting out into all the extremities and dumping all that junk that's been out in the extremities of the cells. So it's the first sign that you have ROSC. So methods for that, we have a special cannula that has one of them on it. Also, if it's a ventilated, it's a little collar that goes over between the BVM and the advanced airway or your King Airways. Same thing, we'll go over those two. Awesome. This one, guys, the vital signs of monitoring, the key for it, for you guys' chapter review, is know those ranges. Okay. We're going to take till 6:55 and then we'll start on chapter 14. Alrighty, guys, here we go. So chapter 14, we're gonna talk about the principles of assessment, kind of the physical assessment. Then critical thinking, decision making. We'll spend some time on this one here too. And then the body system examination. So patient history, we have two different components with it. We have the history of the present illness, meaning why did you call me today? Shortness of breath, car wreck, whatever. And then you have your past medical history. Does this mean every surgery from a appendectomy to a broken arm? Does that matter on a heart attack necessarily? You're going to get all of it, but so a lot of the times when we talk about it too, it's past pertinent medical history too. The other one too that you'll see with this, when you, why are you calling out? I just don't feel good and blah, blah, blah. Well, do you have any other past medical history? Oh yeah, well, I'm a diabetic. Does that change it? Okay. So a lot of the times yes, hugely it changes it. So a lot of the times if it's something that a chronic condition that they've lived with forever, they don't see it as past medical history. So you have to get creative on how you ask it. Because they're like, oh, well, do you have any medical history I need to know about? No. When you look at, well, do you take any medications? Well, yeah, here you go. Well, I take metformin. Well, are you diabetic? Oh, well, yeah. Or you find a blood pressure medication or something like that. Oh, yeah, I've had hypertension or I have high blood pressure. Okay. So some of it, I guess what I'm getting at is if it's a condition that they've lived with for their life for many years, they don't think of it as past medical history or pertinent, okay? Or even part of the present illness, okay? If the patient is, obviously you have to talk to the patient. Sorry guys, you can't just do this all computer. You're gonna have to talk to them to get it. If the patient's unable to respond though, family members, bystanders, if they're in their home, you can go look. Medication list. If you guys, there's an emblem and I'll get a picture of it for when we do pediatrics. If it's on the front door in the glass, you can go look in the freezer and you can find medication list, history list, whatever on that kiddo. It's a program that they started doing because legally every house, if you take a child to it, has to have a fridge. So that was the only place they could come up with. Other things you observe on the scene too. Develop a rapport with the patient. Ask open-ended questions. And with the open-ended question, we're trying to get them to dialogue with us and talk to us. If you use the closed question, and closed means yes or no. Well, versus open-ended questions, how does it feel? Can you tell me what it feels like? You know what I mean? Get them to describe it to you. Versus, does that hurt? Okay, yes, no. So open-ended questions to try and get a dialogue going. It helps get a picture of what's going on with the patient. If you are unable to develop a rapport with the patient, but you find that your partner is able to, and who do you want to have them ask the questions? Whoever they have a rapport with, right? So kind of being mindful of that and watching what it is too. So this one too, this OPQRST, you guys are going to see it over and over and over again. So it's a mnemonic to learn about the chief complaint and history of present illness. So onset, that's their time, right? How long ago did this happen? So it's always in time, and is it days, hours? So we're just gonna have to ask the patient. Provocation means what were you doing when it brought it on? Were you out mowing the lawn? Were you just sitting in your chair? Were you in a wreck? Were you in a fall? Did anything happen that brought it the quality, that's where you're gonna have them describe. If it's difficulty breathing, all this, is it tight in your chest? Is there pressure in your chest? The pain, is it stabbing? Is it a dull pain? Is it an ache? Just have them describe whatever their present illness is or injury. The region is, I mean, it's just like it says on the body. Is it in your arm? Is it in your leg? And then the radiation, like with the chest, okay, is it in your, it's in my left arm and it kind of goes, or my left shoulder and goes down my arm. So it radiates down my left arm. Or if you have gallbladder pain or kidney stones, it's in your back, but it can radiate to the front too, okay? So region of radiation. Severity, that's a scale of 1 to 10, okay? On a scale of 1 to 10, this worst pain you've ever felt in your life, what is this, okay? And there is no such thing as a 12 on a 10 scale. You'll hear it a lot, but there is no such thing as a 12, okay? And then time is how long has it been going on for? But know that mnemonic, you will see that over and over and over again. Along with this one. So sample is what we use to learn about the patient's medical history. And a lot of the times, like with OPQRST, we ask it in that order, but a lot of the times with sample, you're gonna get it in piecemeals on it. You might get events leading up to it before you get allergies and medications, okay? So first one though for S is signs and symptoms. So we throw both of them in. So not only what you can see, but a symptom is what the patient feels, right? Sign is something you can see, symptom is what they describe. Allergies, does the patient, do you have any allergies to medication or any other allergies I need to know about? M, medications, what medications do you take and why? Past or pertinent past history, okay? And that one can be hard because if you ask, you know, a 70-year-old guy or lady, you know, what's your past medical history? And they can jar on for 10 minutes about every surgery they've had until they're back to 10. So a lot of times you have to find a way to rapport with the patient to kind of bring them back in and say, no, I just need to know what it is that's going on here. Last oral intake. It's not necessarily going to affect the way we treat them, but the anesthesiologist is wanting to know that why. The likelihood they're going to throw up if they have to go into surgery. So if they ate 30 minutes ago versus somebody that the last time they ate was 6 hours ago, the chance that the 30-minute guy is going to throw up versus the 6-hour guy is a lot higher. So they'll take, a lot of the times they'll go from, they call them like an LMA or a less invasive airway. If you ate and you had to go into surgery, an emergency surgery, and you ate less than 2 or 3 hours, they'll usually put an ET tube in just because of the likelihood of you're going to vomit. And then the events leading up to the injury or illness. So what were you doing? Were you out mowing the lawn? Were we sitting here? Were you in a car wreck? Did you fall? Just the events that are leading up to it. And a lot of the times that comes into the from the page and your general assessment of the scene. So some history taking techniques with children. Use simple language for these guys. They don't understand the medical terminology. So can you point to me where it hurts? Does your finger hurt? Just use common words with them. Don't get medical with them. School-age children, they can will be able to discuss what they feel and what happened. But a lot of the times too, they can be a little over dramatic, right? Include parents, teachers, and caregivers when you're doing this history. The other one that I always like to add to is if you're dealing with an older person that has problems with vision, a lot of the times if they're nearsighted or farsighted, if you can kind of find where, say, hey, can you see me? And is it better if I get closer? Or if they have a hearing aid and you're behind them talking, they're not going to hear you. Or if you find that, oh, the left side they can hear out of, then you're just pay attention to the patient and try and communicate that way with them too. It's just back to the extremes of age, right? You get to deal with it on both sides of the spectrum. Any questions on history taking and techniques? Oh, the other one with the children, get down to their level. So if they're sitting on a chair, go ahead and try and nail at the floor so you're eye level with them. If you're standing over them and asking them, it's a threatening and kind of puts them in a threatened position, and they're going to clam up and not be as willing to talk to you. And then try and get your history taking on your little kiddos too before we do the physical exam if you can. If they're really sick and we got to find out what's going on, then they're not going to be talking anyway. We're going to be looking for mom and dad or a provider. But try and do as much of the history taking as you can on the child before you touch them. So the physical exam, it truly is performed during or before, during, and after patient history. Okay. So the three things, the primary techniques, right? We're going to look for the overall sense of the patient's condition. So observe, listen. So we're going to auscultate, and then palpate. We're going to feel for other deformities or abnormal findings. So with this guy, sick or not sick, looking at him. That screen's very hard to see. So if you look at this one, he's got fairly good color and things, so he's able to talk to him. Sorry, the monitor for you guys in Zoom land, the one that's projecting on the wall makes him look like he's jaundiced and yellow. Anyway, but no, he's up talking to him. Is he in the tripod position? No, so he's not necessarily real hard at work of breathing. Does he have a breathing or airway issue though? Yeah, because he's already on oxygen, right? So something's there. We have some underlying condition, okay? With him, especially, we're going to want to auscultate lung sounds, right? We're going to listen to the upper and upper and then lower and lower. What was the other one with that? And then palpate too. I would say, just looking at the picture, I wouldn't put him as hot or cold, but we're just want to palpate and feel body temperature on him. So pediatrics, that was short on the physical exam. Get more on the later slides. All right, so pediatric exam, approach a frightened child slowly. If they can be in the arms of mom or dad, and we'll calm there. A lot of the times that's the best place to do it, is do the assessment in mom's arms. Same thing, if there's 3 or 4 of you coming in and coming at him at a pretty good pace with, monitors and bags and all of that, you're going to scare him too. So one person approach, do it slow, kind of talk to him, let him be in the least anxiety or anxious position you can. So we're going to start from the least invasive to the most. So we're going to start by checking their little feet. We're going to start to toes and work up towards the head, and then explain all the equipment before it's used. And a lot of the times, like with your stethoscope, hey, I'm just going to listen to your little heart. You want to feel it? If they can feel it for a second and it gets them more calm to it. Never lie to a child about something that's going to hurt. If you're going to give them an IV or they're going to get a shot, don't tell them, oh, this isn't going to hurt. This isn't going to hurt. Or if they have a broken arm, oh, that doesn't hurt that bad. You're fine. Never lie to them about that. You'll lose their trust and you'll never get it back in the time you have. And then provide for patient privacy, especially as they hit towards the 6, 8 years old. A lot of times they're becoming aware of their little bodies and don't want them necessarily paraded all over. So if we can do it in mom's arm, cover them with a blanket, whatever we need to that way. Some other parts of it too, though, if they don't want to go to mom when you guys are doing the physical exam on them and they want to come to you on a pediatric case, is that a normal finding for pediatric? No. So it's usually a sign of abuse too. So some other things with this, like this is, we're showing you how to do this on a normal kid. Be suspicious if either mom or dad, they don't want to be there, or mom and dad don't seem to have any effect on calming them. If mom and dad don't have an effect on calming them, one of them, they're either really sick and hurting, or there's a sign of abuse. So some of those things to consider with it. So respiratory system, it's most determined when assessing the respiratory is the patient's breathing inadequately. So some approaches to the history of it. So we're going to ask for any existing respiratory conditions. I keep bringing this one up, COPD, CHF, are some big ones that you're going to see. Asthma is another big one that you'll see. And right now, I mean, COVID is one that you could potentially see. Determine if the medications have been taken as prescribed. That's a hard one, especially with pediatrics and the elderly, geriatrics, excuse me. They either forget or take too many or too less. Anyway, so make sure they're taking it as prescribed. Determine the signs and symptoms of this episode match the previous episode. And the reason why we're asking that is, what did they have to do last time for you? And, you know, if this is something they've dealt with, if they're the respiratory problem, and last time when I was hospitalized in the ICU and they had to intubate me, all of that, chances are they're going to do it again. So we're going to want to alert the hospital, hey, we're coming in and just, this is what they had to do last time. He's following the same track. We better be ready for intubation and RSI, whatever it is. Or, hey, we need this medication. We need albuterol, or we need dopamine, or not dopamine, an epi inhaler, whatever it is, just so we can tell the hospital. And it also tells you, hey, last time they just gave me some albuterol and some oxygen and I was fine. Okay. Or last time we just got set up, they gave me some oxygen, I got cooled off and I was fine. Okay, we can deal with that. Okay, so it doesn't always have to be the worst case. It can also say, hey, we did this and we're kind of fine with it. So some other parts of the physical is mental status. LOC, right? Alert, oriented, and conscious. Okay. Level of respiratory distress. That's the same. How are they breathing? Hard, shallow, fast, whichever it may be. Chest wall motion, especially in kids and elderly, if we're seeing those intercostal muscles working. And we're also obviously having some respiratory distress. Lung sounds are the big ones though, guys. You got to listen to those. Do we have good deep breaths coming in? Are we getting in all four quadrants equally in all four? Use of pulse oximetry. I mean, use it. It's going to tell you some great things. The other one that I would add to that is capnography. Put that on and see if they're in that normal range too. Observe edema. So we're going to look to see for swelling, right? Most of the time when we talk about edema, we talk about the calves and lower legs, but you can get it in the hands and also in the lungs too. Get some pulmonary edema. And then fever. Why is it with the fever that we're affecting the respiratory? What is it you're blowing off other than CO2? Heat. So they're trying to breathe off that heat. You'll see that with the diabetic too. They're going to have a higher respiratory and that fruity smell, and it's because they're trying to breathe off that glucose when they get really, really high. Cardiovascular system, so the heart, blood vessels. So these are the patients we see, somebody in shock with other vascular problems. The big thing with these guys is history, right? Is this an existing? So the other term that you will hear with that is this a chronic or is this an acute? Meaning, is this something we've been dealing with So chronic is, it's something we've dealt with for a long time. We take this medications. And a lot of the times, like I said, they don't look at this as it is a history. They just dealt with it forever. Versus a acute, meaning, no, this is the first time I've ever seen it. I don't take any medications for it. Okay. So existing versus chronic versus existing. Excuse me, chronic versus acute. Geez, I'll get that out right. So signs and symptoms of the episode. So what would you guys expect to see as a sign or symptom of somebody having a heart issue? Some swelling and sweating.
Pale?
Punching the chest.
Yeah, I can. Go ahead, Bay.
Being pale?
They'll be pale. Yep. So some of the ones that we were talked about here is the chest, the diaphoretic too, the chest pain, excuse me. That was the other one. Oh, radiating down their arm. Okay. And so some other ones too that you'll see with it, they'll have an altered LOC. So they're not mentating right. So we'll ask them, some other ones too, we'll ask is determine the chest pain using OPQRS2. So for chest pain, when did it happen? What was the onset? What were you doing? P for or onset, when did it happen? Okay. Provocation is what were you doing? Were you out shoveling snow or were you just sitting in your chair? Quality, describe the pain to me. The rate, let's go back to this. Told you guys to all remember it, and now I'm sitting here stumbling all over it. Radiation, that's right. Okay. So quality, describe the pain. Is it sharp? Is it dull? R is the region of radiating, is radiating to the part of your body. Severity is the scale of 1 to 10, right? And then time is how long has it been going on. Trying to think about one too many things about the trees. And then determine the specific characteristics of the discomfort. That's the same thing. Is it sharp? So with chest pain, we want to know, is it sharp? Is it dull? Is it achy? And then the other part of it, does it go away? So when you came in and sit down, did the pain get better or worse? Or is it unchanged? And the reason we're trying to do that is usually angina pain, when you come in and they sit down and go at rest, it'll get better. The pain will go away. When they get to that point where it's a full myocardial infarction, it doesn't matter if they're sitting, standing, walking, the pain does not change. So those are some characteristics we want to ask for. Look for signs and conditions may be severe. So a lot of the signs we've already talked about, or symptoms we've talked, because that's what, or signs, excuse me. So the signs are going to be severe, meaning that it's just like we've talked. They're going to be pale, altered mental status. They're going to have cool, clammy skin. You're going to see all of those with a severe cardiac patient. Obtain a pulse. If they have a really, really weak pulse, you may not be able to feel it in the radio. So then we're going to have to come up and check the current. Okay. Obtain a blood pressure. It's the same thing. If they're really, really sick and down the drain, the blood pressure machine may not read, and you may have a really hard time doing a manual too. Does that change whether you can get a blood pressure and it's really crappy in numbers, or you can look at the patient and say they're really crappy? Does that change our treatment? No, we're going to still do the same treatment. So a lot of this is, if you can obtain a blood pressure, by all means. If you can get a pulse, by all means. But you're going to be able to look at these patients. If you can obtain either one of those, your treatment's going to be the same, because you're going to look at those patients. You're just going to look. They're going to be all of those signs that you guys talked about. Note the pulse pressure, that's the strong or weak. Look for JVD, jugular vein distension. And you're gonna see that in their neck, right? You're gonna see that jugular vein. It's just gonna be great, big and bold and distended. Palpate the chest. We're just looking forward to, if you have somebody like that, you better have that strip, chest exposed to palpate it too. We've gotta get down to the skin and see if we have a penetrating injury, if we're getting intercostal muscles, if we have swelling, rashes, anything like that. Observe the posture of the patient and breathing. So this is, are they tripoding? Are they sitting back? Are they laying back? Are they just flat out unconscious? And then position them in as you're moving them. If their posture and the ease of breathing is in the tripod position, then we're going to transport them in the tripod position too. Okay. You don't want to do anything to make it harder for these guys to breathe or for their heart to pump. Nervous system. We're going to look at the mental status. And it's got to be normal for them. There's some people, well, let's go to the next slide. And then signs of dysfunction of the body. So what would be a sign of a dysfunction of the body? And what would be an illness? Who do we got out there? We're going to pick on somebody here for a minute. Kathy. Can you hear me, Kathy? Will, can you tell me what injury is that you might suspect to see a body dysfunction? And you guys can take a shot. No answer is wrong, I promise you. With a nervous system.
Spinal injury.
Okay, spinal injury, perfect. So you'll see some paralysis, right? Or you're gonna have a point of severe pain.
It could also cause involuntary movements and bowel movements spontaneously.
Yes, yep, perfect. And then the other one, the big one though too, is stroke. You're gonna see that dysfunction in a stroke patient. Thank you, Will.
Yep.
All right. You're good, Kathy. Thank you, though. All right, mental status. Come on, work with me, clicker. So determining the patient's mental status. Okay. And then we also have to determine with that is the patient's normal mental status. So if we have somebody that has Downs, autism, some of their mental status, they may seem off, but that's just normal for them. So who's your best person on somebody? If you're seeing somebody that's not acting what you would consider normal, who's the best person to ask? What's that?
Family member.
Family member or bystander, yep. Caregiver, family member, bystander, hey, is this normal for them? Okay. Obtain a history of neurological conditions. That's the same thing like we said, do they have a history of some mental down, something like that? And then note the patient's speech. There's some people that would listen to these lectures and wonder if I have some neurological disorders on my speech. So same thing, you're just gonna have to find out if that's normal. So we're going to perform the stroke scale. We'll go over that when we talk on strokes as far as like this. There's two of them. There's the Cincinnati stroke scale, which is what most people use. There's the Los Angeles stroke scale, and there's one other one, but most people use the Cincinnati. So we'll go over that with you when we hit strokes. We're going to check peripheral sensation and movement. So peripheral would mean where, JB? What would a peripheral sensation and movement, where would it be at?
Fingers and toes.
Fingers and toes, perfect. Okay, we're gonna see the other word you'll hear for it when we start talking on it is PMS. So pulse, motor, and sense, okay? Okay. You'll either hear it as PMS or CMS. So circulation, motor, and sensory, or pulse, motor, and sensory, or circulation. Yeah, sensory. Pulse, motor, and sensory, or circulation, motor, and sensory. Gently palpate the spine, going back to what Will was saying. We don't want to do this very hard if they have some kind of a spinal injury. And if they have a spinal injury, as you're gently palpating that spine, it's not going to be that hard to find. Okay. Check for the extremity strength. This is when we do it. You say, hey, can you squeeze my hand? And what are we comparing it to?
Equal.
Equal. Perfect. So we want it, the left hand to squeeze as tight as the right hand in theory. Okay. If they're not, what's the next question? Is this normal? Okay. Because a lot of the times a stroke patient that's survived a stroke, whatever side they had the stroke on is going to be weaker. So if they had a stroke 8 years ago and we're doing an assessment on them and it was a left-sided stroke and now their left side, they can't squeeze as well, that's not necessarily an abnormal finding for this patient. Perfect. Check the patient's pupils for equality and reactivity. We kind of hit that when we talked on vitals. We're just looking to see, hey, the pupils might tell me I have something going on inside my brain too. Examine the patient's gait. So what does a gait mean? How they walk, okay? You know, if they drag their one foot, if they have a limp, and it's the same thing. A stroke patient or somebody that's had some neurological injury, they may drag their left foot. They may have an abnormal gait, but it may be normal for them, okay? Any questions on a neurological assessment? And a lot of the times with this, the other big part on it that comes with me is just as you talk to them, right? Is as you're talking to them and all of a sudden they're starting to slur their speech or they can't remember things or they have days. It's something the neurological exam, you a lot of the times don't think about it, but the full time you're treating a patient, you're doing a neurological exam and comparing it. Hey, 20 minutes ago when I picked this guy up in his house versus now something's changed. He's not talking right, or if we've done it right, golly, he was really had some funky neurological stuff going. We gave him oxygen, we gave him a little glucose, and now when we get to the hospital, he's maintained great. Okay, so you're truly the full time you're assessing a patient, you're doing a neurological assessment on it, whether you put it down as a documentation or not. So endocrine, the most one that you're going to see in an emergency situation is a diabetic patient. The rest of them have a fairly slow onset, or once they go, they have a very fast outcome too. So diabetes or thyroid history too, we'll tie both of these onto it. So current medications, and same thing, whether they're being taken properly. So some major diabetic medications, you're going to see metformin is usually one that's not insulin dependent. Humalog, Novolog. I can't remember the third one now. Your logs are usually like Humalog and Novolog are a form of insulin. They have some longer acting ones now too. But those are some common medications you'll see with it. But it's the same thing a lot of the times when you ask them, trying to get a history until you get this medication list, it's something they deal with every day and it's not an emergency and it's not pertinent. It's just something I live with. Okay. Whether the patient has eaten or exerted energy at an unusual level, especially for a diabetic. So if they took their insulin before they ate and something happened and they didn't eat, their blood sugar can go down and we're going to have a diabetic emergency. Or if for some reason they ate and went out and wasn't planning on shoveling a 10-foot hole or whatever and exerted a lot of energy, they can burn off a lot of that glucose, but the insulin's still working, so it can throw them into diabetic emergency. The other one too, with all the pumps now, and that's where the medications, there's a few different ones they put through the pump now that are some different ones. But if they have a pump and they start going down and have an emergency, look at wherever that insertion site is. And you'll know if they have a pump because it looks like a pager or a little, it's a black box and it's got a hose going up underneath the clothing, usually worn on the belt because it can go into the belly or down in the thigh. Follow that, see where it's at. If there's a lot of sticky wet around the little patch they put over it, then their pumps come on. So instead of going into the skin and into the blood, it's going on top of the skin and it won't absorb the insulin. So there's some things, tips and tricks over the years to look at for these guys. Whether the patient is sick. So when you get a high fever, it's the same thing. You burn through glucose really fast, which is usually what gets little, when you guys go to, if you get a chance to go to a NICU unit or anything like that, and you get these little kiddos that are sick, they're burning through sugars and they're not going to give them that. And we've already talked about the blood glucose or uses in this. Those insulin pumps are, well, let's talk, we'll hit on those. Insulin pumps are really, really nice. A lot of them are Bluetooth to the phone, things like that too. And if they hit a certain level on them now, and they have cell phone service, they'll actually call 911 or a caregiver to alert them that something's going on. And then they can either page a caregiver or send an EMS crew out. Evaluate the patient's mental status. That's the, like I said, you're doing that all the way through. Observe the patient's skin. Diabetic will always be pale too when they're out of emergency. They just look for crack, pale, cold. Maintain a blood glucose level. We'll go over that, how to do that with the glucometers. Look for an insulin pump like I talked about. It's a little black pump and it's got a hose going to it. And then look for medical jewelry too. So if they have a jewelry, a necklace, a bracelet, there's a lot of times too. Like in the summer, if you're out swimming or whatever, they'll wear an anklet. It'll take the bracelet, put it on their ankle. All the other thing when you're doing your physical exam and you obtain the blood glucose level, we've hit on this hopefully enough already, but ask what's normal for them. Or if they have, a lot of times you can tell a compliant diabetic versus a non-compliant because they have like a log or whatever that will tell you, hey, this is where I'm at. Versus an non-compliant will just say, I don't know, I just had a sandwich and I usually take 3 units of Novolog or whatever. But try and find out what normal is for them. Oh, the good old GI system. Okay. Most of the time, you won't deal with the GI other than some bleeding. We'll go over that one. Okay. So looking for what's going in and what does come out and what it looks like when it comes out. You guys, I'll promise you, the first time you smell a GI bleed or somebody throwing up, you'll never, ever forget it. Because it has its own very unique smell. Okay. But the other part with it too is if looking at, if they've ate a bunch of jalapenos or whatever it may be, or a bunch of cheese. The other one we deal with that sometimes you get called for as little kiddos is, oh, my stomach hurts, it hurts, it hurts, it hurts. And you ask them, well, what have you ate? Oh, cheese sticks and a slice of cheese, you know what I mean? Every possible thing that could cause constipation for these kids is what they've ate for the last 4 days. And you'll see it in 5 and 6 year olds because they're potty trained And a lot of the times they're getting to that independent stage where I don't want mom or dad to come and help me in the bathroom, right? So you'll ask them, well, when did you use the bathroom last? When was the last time you pooped? Like 2 days ago. Okay. So some of that, where you'll see that, and the same, you'll see that with older people, but sometimes in the reverse, they'll eat it and then 5 or 6 hours later, it's coming out. And it's not very well digested. So, some assessments we want to do with the pain or discomfort, it's the same thing, usually with GI, unless it's a GI bleed. It'll be a diffuse pain, meaning all across their stomach. When you start to pinpoint it, it's actually easier because then we can see what is underneath the anatomy. So if, oh my gosh, it hurts in the upper left, well, there's something with your stomach or spleen or whatever. Lower right, oh, okay, that's your appendix. So pain or discomfort, kind of the OP, use your OPQRST on this one too, to get a little more description on it with your history. Oral intake, when was the last time you ate? History of gastrointestinal issues. Most of the time with these, this is, if it's severe enough that you're getting called, this isn't the first time they've dealt with it. Well, they may have a GI bleed, like for my family, my dad has Crohn's, we all have IBS, so we all have gastrointestinal issues. So get some history that way too. And then ask, for what makes it better or worse. Is there certain foods that make it worse, or is there certain medications that you have to take? Was there vomiting, especially, okay, did you take, what this kind goes back to diabetic too. So did you take insulin? Yeah, I just been sick and I threw up. Okay, so their body didn't get any of that sugar that they just took, but we just took insulin. So it's going to drop them either way. Okay, so vomiting, especially close after eating, or if they say I haven't ate anything for 8 hours, but I can't stop vomiting or dry eating, that's another one too. That's okay. Then what's in them? Bowel movements. When was the last time you had a bowel movement? And you have to be specific, because if you say when was the last time you used the restroom with the GI one, well, I just went in and used, I peed 5 minutes ago. I haven't had an issue. Okay, when was the last bowel? Be specific with it. Oh, this is the final. Okay, observe the patient's position. A lot of the times they call it the guarding position. So they'll be hunched over and they'll have their hands in a cross or across their stomach, putting pressure, guarding that stomach. Because movement or moving it or air or pressure makes it hurt worse. So they're going to be in the guarding position, which makes it a little hard to assess the abdomen, right? A lot of the times you're going to have to ask them, hey, just lift your arms just a little, let me look. We talked about pushing on the 4 quadrants. You're still going to have to do that, but if they say that pain's in the upper left, what's the last one we do? Upper left. So whatever quadrant they're saying that pain is in is the last quadrant we check on our physical exam. If they say it's a diffuse pain and it's just all across the stomach, then it doesn't matter which one you do first or last. But if they can kind of pinpoint or identify pain in one quadrant, that's last one. And the fun part. Inspect vomitus or fecal matter if available. GI bleeds, like I said, you'll see it, but the other thing is if they're passing it really quickly, you'll actually be able to see food particles still in it. They just haven't been digested for whatever reason. Oh, and then inspect other parts of the gastrointestinal system. What other parts would that be? So a lot of the times your throat, mouth. See if we see any irritation there. Guys, So with the immune system, most relevant that we're going to talk about is anaphylaxis. It's the same thing too, guys. History of allergies. This, if it's severe enough that you're getting called 9 out of 10 times, this isn't the first time that they've had it, okay? So it's an exposure to a known allergens. A lot of times we talk about hay fevers, nuts. I mean, it could be dogs, cats, whatever it is. But it's an exposure that they know if they get exposed to it, they're going to have a hypersensitive immune system, and the immune system's going to overreact. And then some of the histories you're asking is, what are typical reactions like? And what we're asking there is, okay, what did they have to do last time? Did you have to get multiple epi shots? Did you have to go to the hospital? Did you have to do IVs? What did we have to do last time to treat this? Because usually it follows the same path. The only difference is the severity or the time that they go from good to bad is increased every time they get exposed to it, usually. So if this is the 5th time that he's got stung by a bee in 2 years, and the first time he was all right, had to go to the hospital, but ultimately it was okay. Then the next time, spend a day at the hospital, and then the next day, 2 days at the hospital, 3 epi shots, whatever. Just ask him what the typical chain of progression is for him. History of asthma, too, same thing. If they've been around pollen, hay fever, whatever it is. Then we're looking for those symptoms of tightness in the chest or throat. Why is it we're looking for that? What's closing off that we're worried about? Airway. Okay, perfect. GI distress and itchiness or a rash. So the body's also too, it's going to get rid of whatever it can. Okay. Itchiness, the skin, it's that hypersensitive immune response. And then also medications for allergic reaction, which are, Jessica, can you tell me what a normal medication for an allergic reaction is?
Can you hear me?
Yep.
Okay. Like an EpiPen?
Perfect. Well, usually allergic reaction is EpiPen is the first line. And then the other ones you'll see are Benadryl or the diphenhydramine is the other term you'll use for Benadryl. Okay. Perfect. Thanks, Jessica. So the physical exam, we're going to want to look for the point of contact with an allergen. If you can draw a circle around it too and note the time. So if you take your pen, let's say you got a bee sting on top of my hand. And when we get there, it's the size of a quarter. We're going to draw a dot around that and note the time that we did it. And then if in 5 minutes it's doubled in size or whatever, we're going to note that. Okay. The other part of it too is if we can see where that allergen touched and you can see, say, a stinger for a bee sting, and we can see the stinger in there, we're going to get rid of it. Or if there's still the allergen, like an allergic reaction to peanut dust or something that's on their hand and it's still there, we want to get rid of whatever contact it's having with that allergen. Skin and rash comes with it. Where's the place that it usually shows first too, though? At the site, and then the chest is the next place you'll see it. So usually the first place you'll see it is at wherever the contact site was, and then it goes to the chest. Expect the lips and mouth for swelling. Goes back to, we're checking that airway, right? That's the big worry we have with these allergic reaction is that airway closing off. Listen to the patient speak. It's the same thing. We're just checking airway. If they can talk to me and speak easily, then we have an open airway. And then we're going to listen to the lungs to assure adequate breathing. And we're going to teach you guys how to give them an EpiPen, which is what they need. So for you guys in EMS, the medical disease or diseases in the system are rare, but we do have muscular dystrophy, all of those that come with it. But it's usually, you're not called to them for that. It's like a lung issue or a heart issue that goes with. Okay. Most of the time when you guys are seeing these, it's going to be part of a trauma examination. It's the same thing though. We've talked about, grit, speech, all of that. Is that normal for these guys? Was it a prior injury? Okay. The other part of it, if we're seeing a lot of bruising, are you on a blood thinner medication? Who would you suspect to be on a blood thinning medication? Yep, so some kind of history of congestive heart failure, previous stroke, previous pulmonary or PE, any of those things that way too. So if they say, oh yeah, I'm on a blood thinning medication, that's the next question you want to ask is try and get specific on which one of them it is. Underlying diseases or conditions that make fractures more common. What's one that elderly females get? Osteoporosis. Perfect. There's some other ones too, calcium deficiencies and stuff like that, that can make fractures more easy too. Age is another one too. That's an underlying disease, right? Sooner or later it kills all of us. History to determine if the medical problem caused the traumatic injury. So did you have a stroke and that's why you wrecked your car? Did you have a heart attack? Whatever, was there a medical reason that caused the trauma? Don't get tunnel vision on that one. So we're going to inspect for signs of injury such as deformities. We're going to go over so the mnemonic, and I'll send this out, or we'll talk about it in plans on actually. The mnemonic we're going to use for it, and I think it talks about it in trauma, is DCAT BTLS. So we're going to look for, when you're looking for signs of an injury, I'll say it now, you don't have to memorize it just yet, we'll go over it more, but deformities, contusion, which is a bruise, bruising. Anyway, so we're looking for lacerations, tenderness, and swelling too. Palpate areas with suspected injury, but it's the same thing. A lot of the times if you can palpate that last versus first, just because we don't want to cause any more pain. Or compare sides for symmetry, especially when we start dealing with fractures, the suspected fractures to the lower legs. The first sign that you'll see a complete femur fracture is whichever leg is broke, it's going to be 1 to 2 inches shorter and twisted out. Same with an arm. If we get a humerus break, the arm will usually kind of twist and it's going to be shorter than the other one. Because you look at it, those are great big muscle groups, and when they contract, which is what the body normally does with pain, it contracts and it has a lot of force. This broken femur is going to take a lot of force, which we'll show you how to treat, but it is going to take a lot of force to overcome those large muscles. Be alert for crepitation. So what is crepitation? Yeah, it's the bones together. The best way that I can describe it to you guys, for you guys that hunt, if you feel like if you shot a deer or an animal in the leg or in the chest and you move that around, once you get them, you can kind of hear and feel that. You'll feel it rubbing and you'll hear it too. It's not as fun to hear on a human, but that's the same thing that you're hearing, is that bone on bone and part there with it. And then assess the patient for head to toe if there are multiple injuries or if the patient is unresponsive. So if they're unresponsive, this is where they got to be the trauma naked, right? All the clothing has to come off. The other one too, if you have multiple injuries, meaning distracting injuries is the term I like to use for it. So if we have a really bad distracting injury, meaning is road rash more painful than a broken arm?
Probably.
Yeah, so on a motorcycle wreck, you're going to get somebody that complains of a lot of pain. And they can have a broken arm or a broken leg or a large laceration. It's just, but that is distracting, and that's what their complaint's gonna be. So you're gonna have to go head to toe on these guys. So some critical thinking and decision making here. Diagnosis, and this is where you can see the age of the EMTs as you guys get out in the field. Until we went to the National Registry, we got it hammered in our heads. We do not diagnose. And now as we start teaching it, we 100% want you guys to diagnose and look at it. So if you get in the field with somebody that says that, oh, we don't anymore. I've just had some students that have had to deal with this. No, we do diagnose. That's 100% part of it. So a diagnosis is the label for the condition. Is it a heart attack? Is it a stroke? Is it a seizure? Whatever it may be. And we're going to use all these things that we've talked about over the last two classes based on our history and physical and vital science to determine that. It's both your physical and your intellectual activity too. Meaning that the more you do this, the more patients you see, the more exposure you have, the more reading, whatever it is you do, the easier it's going to be to diagnose because you're seeing it before. Clinicians have different level of training, experience, or time technology too. So if you go up to, you're taking a suspected heart patient to Utah Valley to the cath lab, they're going to have a ton more training experience, right? Because that's all they do. They see 10 or 12 of these every day. So you walk in the door and they're going to see it and just run with it, okay? Don't look at it as a failure on your part. You may not have seen a heart attack or a stroke for 6 months. So, and this is their 8th one of the day. They just get more experience, exposure to it. And then techniques vary among clinicians. Sometimes that can be frustrating if you're used to dealing with one doc versus the other on how that goes. But a lot of it, you just got to build a rapport with them. They're going to get to the same place. They just have different techniques. And you're also with that different types of techniques with clinicians. We try and teach kind of a standard head to toe for EMS, but the longer you're at it, they may have a different technique to go with it too. You got to talk to them, right? The nice thing is I love how they use this clinic setting with a guy in there in a robe and all of that to come in and talk to it, because that's not where your interview and talking to this patient is going to be. And most of the time, it is not in a controlled environment. Okay. So you got to learn how to deal with that and get down to them. All the techniques we've talked about in high level using common language, but it is, you do got to talk to them to get to that diagnosis. List of conditions or diagnosis, and we want, so the term is differential diagnosis, because multiple signs, the same sign or symptom can be for multiple diseases, right? So we don't want to just tunnel vision down to one. So we're going to have multiple diagnoses that we're going to think at, and then we're going to use further evaluation to try and lead down this. Okay, well, let's look at this as an altered LOC. And we're going to look, okay, what's one of the, so if I say somebody's got an altered LOC, they're not acting right, what are some things that we want to check? Blood glucose, right? Head injury. Okay, so if we check those, blood glucose is normal. So, because I'm thinking my differential diagnosis is okay, we either have a blood problem or glucose problem, we could have a drug problem, we could have a medication problem, or we could have an injury. Okay. So the first one I want to try and eliminate or go to is the serious ones, so drugs or glucose, right? So glucometer comes back, it's 90. Not necessarily way out of whack, right? So we're going to push that into the unlikely condition now. We do a check of his pupils, and they're pinpoint and unreactive. And now we're looking at drugs, okay? Or if that came back and was reactive, then we're gonna look at, oh, then we're gonna check, that's normal, pupils are normal, glucose is normal. Then I'm gonna palpate the back of the head and I feel some crepitus in the back of his head or on the skull. Ooh, there we go. That's the final diagnosis of the skull. Or if the blood glucose would have come back, oh, the diabetic emergency. Or the pinpoints would fix and dial or fix the dial or pinpoint and unreactive. Geez. Then we're saying, okay, my final diagnosis is a drug overdose. Okay. Does that make sense on the differential diagnoses? And you're just trying to eliminate by excluding other unlikely conditions, either for further test or just diagnosis that way. So it's got to be quickly to rule out the life threats, just like we just talked with that one. We're going to get rid of the blood glucose and drugs. Those are the two big ones that I have right now. And if all possible, we're going to ask the patient, family and friends. And I mean, some of it's a no-brainer too. If you ask him, have you been doing drugs or have you been drinking? And he smells like a winery and there's beer bottles and everything all over. And he says, no, I'm not believing that patient. Okay, so some of it you got to look around too, but ask family and friends. We're going to perform our physical exam and then focus on ruling out worst case scenarios. So the red flags, it's the same thing. Those red flags are specific to ABCs, right? If we have any indication we have some compromise on any one of those three things, it's a red flag and I got to treat it as a serious. And then also too, you may be responsible for multiple patients. And a lot of the time we talk about this in triage and things. If there's more than one patient in the ambulance, you're going to have more than one of them. And if one of them has some red flags and the other doesn't, you may not get to do a lot of diagnosing on the other one. The other one I'm going to throw out on that one too is just remember too, if you get to the ER, a lot of the times, especially if you go to like Utah Valley or whatever, they have multiple patients, but even Sanpete Valley, there may only be one nurse. She's got 5 beds or he's got 5 beds that they're trying to deal with too. And 3 of those 5 may be critical. So just be responsible. Know that he's not only responsible for your patient, but the other 5 beds. And a lot of the times too, it's truly just, it's a hectic situation. The doc's in there, the nurse is trying to get blood pressure cuffs, oxygen, heart monitor, respiratories in doing stuff, labs in trying to draw blood. It can get a little hectic in there too. So you'll see that picture a lot. For you guys too, though, your approach to diagnosis does have to be very efficient. And we'll hopefully, I do like that we went to the NRMT stuff and their the skill sheets because it breaks it down to a very organized, methodical way to do it. And if you follow that page and their skills, the way they teach them from head to toe, or from top to bottom of that sheet, you won't miss anything. Okay. Then you're going to have to be available for another call as soon as possible. Does that necessarily mean equipment ready for the next call as soon as possible? No, a lot of times the biggest ones are mental and trying to shut off the last call long enough to deal with the next call. You guys are going to work, like I said on that picture, you're going to work in an uncontrolled environment. It may be alongside the road, it may be in the home, but it by no means is controlled and set up and clean, sterile, any of those things for you guys to deal with. You're going to have limited tools and skill set, and I hate that they put the skill set on that because you guys have the skills. You'll have the skills that you need to treat them. Sometimes it comes down to tools, though. But that's where we talk about requesting additional resources soon. And then the narrowed educational focus. A lot of the times we do look at the now, what's going to kill you now, and that's what our focus is on, is preventing that, and then the long term is somebody else's. But just because of that doesn't mean that you're not educated. I hate those last two on that one, I'll be honest. Follows the same steps as emergency, must be as an emergency physician, so you must be abbreviated or limited, meaning that we're not gonna spend, you know, like when you deal with somebody that deals with joints and whatever, they're gonna spend a lot of time in those joints. Or GI docs, we spend a lot of time with that, we gotta be checked for the emergencies and moving on. Consider the most serious condition associated with the patient. So somebody that comes across difficulty breathing, what's the most serious condition they could have? Heart attack, kind of that way. Somebody with a chest or with a stomach pain, severe stomach pain, is a GI bleed. So we'll go over some of these specific emergencies in later chapters. So, but we're gonna always assume the worst until it gets ruled out. So for me, if it's a chest pain, difficulty breathing, it's a heart attack until I get an EKG on them and check some other things. And even then, it's still gonna be like, we're gonna treat them like that. And by ruling out the most serious condition or not being able to rule it out, it's how we're gonna create our diagnosis. So you can reach a diagnosis, but your work is not done. Why is it not? Let's see. So Danielle, why is our work not done when we reach a diagnosis? Stupid thing's not going. You there, Danielle? Can you hear me? All right, it's not working. I can see you're unmuted, but it's not playing on my end, Danielle, sorry. So the reason our work is not done is just because we know a diagnosis, now we know what's that guiding us to. Our treatment, right? Yeah, so if we find out that this is a diabetic, does that mean our work's done? Yeah, you were dead on, Danielle, thank you. So Danielle, in the chat part of it says, because you have to treat them and get them to the ER, right? And we're going to use those diagnoses. The reason we come to one of those is exactly what you guys are saying. It's guiding our treatment for this patient. Perfect. So approach to diagnosis and medical shortcut and biases. So here's, well, we'll go through this and we'll cover it a little bit on each one. So experienced physicians learn hiatuses or shortcuts or pattern of recognition. So a lot of the times they'll say, oh, yep, that's a cardiac because I've seen that same thing 10 different times. It features, the downside of it is it features a narrow possibility. So a lot of the times they're not willing to, when they get into those biases and shortcuts, they're not willing to look at other potential causes. Nope, it's an MI, it's an MI, it's an MI, or it's a PE or whatever it may be that they're focused in on. If it is a specialty though, that's the downside of it, okay? The good part of it though, is if they are experienced, they can reach difficult diagnosis more quickly. So a neurologist is going to be able to find a neurological problem quicker than an ER. Comes down to their specialties too. But what they're looking at, that pattern of recognition, like I said, they're looking at the last patient that came in that had shortness of breath, red bloody sputum was pneumonia or influenza or COVID or whatever it was. So, oh, shortness of breath, red sputum, and in the right age range, boom, that's the, it's gotta be that COVID or whatever it is, okay? So some common shortcuts is, trying to think of how I want to work some of this. So the representative is meaning that's the signs and symptoms. The availability to, and that's resources. The scary one for me is overconfidence. That can be good and it can be bad, but a lot of the times it can cause some problems too. Confirmation bias, meaning it's the same things, different diseases can have a lot of the same signs and symptoms. So they'll take those, well, it's, I'm gonna use extremes here. Well, I'm saying it's a heart attack and I'm saying it's GI. Well, they both have shortness of pain and blah, blah, whatever it is. So it's gotta be this. And so you can argue back and forth. And then search satisfying too, meaning that they're gonna look for those signs and symptoms to meet their diagnosis. So they narrow it to it. Does that make sense? And that's the same with that illusory correlation, meaning, oh, that's kind of a stretch to say that a heart attack is going to have pain in the lower left flank, which is indicative of a kidney stone. Oh no, I've seen it this one time that they had that. Okay. So they gotta be careful with that. And not only do you see that in hospital, but you'll see that in EMS too, that, oh, this is the same patient we seen the other day and this is what he had. And then we get narrow-minded in, we don't look at all the signs and symptoms, we just find the ones that meet ours. So be careful with that as you go through. Okay. So how can you guys as EMTs learn to learn like an experienced emergency physician? So learn to love ambiguity. I made that one up. Anyway, a lot of the times you're not going to get very decisive. You know, we talked about when you guys did the CPR class for me that, oh yeah, this left-sided chest pain that radiates down my arm up into my jaw. A lot of the heart attacks that you're going to see are not going to present like that. It's going to be, I just don't feel good, or I'm having difficulty breathing or whatever. So you're gonna learn to love them, and you're gonna learn to treat it, and it is fun. It is for you guys that like games or mysteries. It is kind of fun that way because it's just a mystery game we're playing here. Understand the limitations of technology and people. We don't have as X-ray or ultrasound or whatever or a full lab in the back of our ambulance. So we're going to learn to understand those limitations, but there's ways around it. There's some other signs and symptoms that we can look for. So, you know, a GI bleed or pregnancy or broken bones. There's other ways we can get blood, find diagnoses without those technologies. And then the hard one that you guys have, when we go on a patient, there may only be 2 EMTs in a drive, or there may be you and another EMT, and that's it. At the hospital, they have lab, they have nurses, they have physicians, they have respiratory. You know, some of our smaller hospitals, it takes a minute to get those things in, but the larger hospitals in the ER, they're in the ER right there ready, waiting to go at a moment's notice. So they have a lot more resources as far as people go. Realize that no one strategy works for everything. That's the one thing that I'm going to tell you guys is you got to be adaptive. We talked about the one, or I don't know if you remember, like we had the one down at Suffolk that when the wall caved and flung him from shield 10 to shield 1, and he hit his head, his knee, his back, he just tumbled down those metal shields and toes. And we stuck buckets and blankets and rags. You guys, rags are just a big tarp we used to do adjust air with all around him to just get him out. So would that work anywhere else? Probably not. So realize that not one strategy works. Know how your tools work, and you can figure out how to make them work for your situation. Form a strong foundation of knowledge. When you guys are done with this class, don't stop learning. There's gyms, there's EMS 1, conferences, trainings that the services provide. Keep going to those and keep up that strong foundation of knowledge, and then add to it as we go. As you guys can see, that top one for me is hard. Organize data in your head. A lot of the times too, if you can organize it in your head, write it down too. A on the back of my gloves, a lot of my vitals and stuff all right there. Just because then I don't have to organize it in my head. It's right there. Change the way you think. And I hope as you guys go through this class that we can really help you change the way you look at that and the way you look at an injury, and what to watch for from there. And then learn from others. As you guys go out into the field, you're going to be with experienced providers, 20+ years, physicians, nurses, ER, different conferences. Take the opportunity and learn from those guys too. And then after every call, you learn something. Even I do after every call. Reflect back on what you've learned and how we can incorporate it into our next emergency that we go to deal with. All right, there's that chapter. Let's do 8:20, guys, and we'll finish off the last chapter for the night. All righty, guys, here we go. So chapter 15, we'll talk on our secondary assessments now. So topics, we'll cover it, secondary, both medical trauma and then our detailed physical exam. We are not going to finish this chapter by the end of tonight. So at 9 o'clock, we'll end where we end, maybe 5 after 9. We'll end where we end and then we'll pick it up next week. There's 97 slides and I can't do that in 30 minutes, so, or 40 minutes, whatever we got done. So the secondary assessment. So we're going to throw it into 3 categories. We're going to talk about medical trauma and then an unknown patient. Or the other term for that is an unresponsive patient. So the physical exam, we're going to do that with head to toe. And then your patient history, so that's your past medical and the history of the present and their vital signs. The physical exam, too, with that part of it, we also re-examine any life-threatening injuries. So if we found in our primary assessment that we had a major bleed, when we do our head to toe, we're going to reassess any of our treatments that we've done. So that's part of the physical exam, is we're just going to see if our treatments are working. And all of this really does go back to guiding what our treatment is as we're doing this secondary assessment. So we've hit on this. Hopefully this is something you guys have caught to. So a sign is something you can see. Symptom is something the patient tells you. And then reassess, reassess, reassess. I think we get into this in a little bit too, but on an unstable patient, remember that every 5 minutes, and then a stable every 15. So assessment of the medical, we're going to look at how they can communicate with us, right? An unresponsive person versus responsive. So responsive can answer history questions, unresponsive can. And it's the same thing as we thought care. A responsive one can obtain the medical, we can perform a physical exam, we can get our baseline vitals and administer innovations and transport the patient. So we're going to obtain the patient history from the patient. Then we can talk to bystanders if he's unable. We're going to base questions on the chief complaint or observations, meaning, okay, you're saying you have left arm pain. That's what we're going to ask. Is it radiating? Is it sharp? Is it dull? Simple, open-ended questions. And then we're going to use the sample mnemonic, which is signs and symptoms, allergies, medications, past pertinent history, last oral intake, and events. It can be your information gained by tailoring history of the patient's chief complaint, meaning how they answer a question is what's going to guide how we gather information about this guy. Obtain questions or ask questions pertinent to the chief complaint, right? If they're having an allergic reaction, we don't want to ask, well, why is your toe bigger than the other on the left foot? I don't know. Sorry, that's just some, we want to keep the chief complaint. Now, does the chief complaint necessarily mean that's what their diagnosis is? No, most of the time it's in the, at least in the general area, but we're going to ask specific questions about it pertinent to that. And a lot of times if it's something different than what their chief complaint is, you can guide them through some of those things too. Perform a physical exam on a conscious or on a responsive person that's usually brief, especially on a medical examiner areas that are concerned based on chief complaint. So if they're saying, oh, my legs are itchy and just something feels like there's crawling up my legs, then we're gonna wanna do physical exam. And that's gonna mean if they got pants or whatever, they have to be able to roll them up, or we're gonna have to take them off to look at that cheek complaint area. Same thing, if they're saying I have problems with my chest, we wanna be able to expose the chest, see if we have any rashes, anything like that with it. So baseline set of vitals, it really is essential to these medical patients because that's what's gonna, what we're gonna compare to. So our initial set of vitals, if we doing our treatment right, we want them either to stay where they're at or improve towards the normal range, right? If, if they're trending the other way, then we know either A, we're not aggressive, or we missed something, we misdiagnosed somewhere, or we need more treatment. But we gotta get that baseline vital just so we know what we're comparing apples to apples here. Take a manual blood pressure to verify the accuracy of the automatic blood pressure device, especially on the older ones. Or if you're on, for like us at the mine, the bumpy roads and stuff like that can really mess with those automated ones too. We're gonna hit you guys on this one too with the, when we start doing the hands-on. On whether they're an immediate transport or delayed. So critical patients are always a rapid transport or prompt transport, especially if they're complaining of anything to do with your ABCs. We've already hit this on the pediatric note, we'll kind of brush over it again. So get at their same level, right? We want to be talking to them, not above them. So if they're same level or even lower. Put questions in simple language. They're not going to understand the medical terminology with it. So simple language. And then also ask mom or other caregivers for information. We've already hit on that, right? For our physical exam on the patient for complaining of shortness of breath, we don't see the chest, throat, any part of the respiratory system. But also with the respiratory, we hit on it too, the last chapter. Remember, their skin is also a big indicator for respiratory problems. Unresponsive. This is really the game of, what's that? Where you had to get the bone and stuff without touching it. Operation, yes, this is the ultimate game of operation when you have an unresponsive patient. Begin with the physical exam and baseline vitals, and then we're going to gather history from relatives and bystanders. The reason we got to get that physical head to toe just so we can see if we make sure we have all our ABCs covered before we move on to anything else. Gather history from relatives or bystanders, do a rapid assessment of the entire body. So the physical exam is similar to the head to toe exam for a trauma patient. It really is, other than we're going to focus more on the head, neck, and chest area and the abdomen, because those are where our core vital organs are. And then the posterior, that's the one that a lot of times we miss, is we don't flip them over on their back. And a lot of the times, like medical patches and stuff like that, they put on their back. And so we'll miss those. So make sure that you flip them and look on their back too. Excuse me. In the neck, the JVD, or jugular vein dissection, distension. Well, I can't talk, I promise. We're looking for that. Like I said, the first time you see it, just that little jugular is great, big, distended, and you can almost see a pulse in it sometimes. And then medical identification devices, so the allergic reaction, all of those ones to it. Chest, we're looking for the breath sounds, and it's the same thing, guys. Hopefully after you're done with the 100 assessments, you're going to know what normal sounds like, so that when you hear that abnormal, it's going to jump right out to you. Do you guys know what distension of the abdomen means? It's swollen, yep. So a lot of the times, like we had one up Maple Canyon that she fell, I want to say 90 something feet. And when I got there, it looked like she was pregnant. And in reality, she wasn't. She just bled to death into her stomach. So she had a great, big, firm, tight, rigid stomach. Some things you're looking for there, tenderness. Also, too, you want to watch for that distension is if we're bagging too. Pelvis incontinence of urine or feces, meaning they use the restroom without any control. The body, when it goes into shock and it's trying to do whatever it can, it gets rid of whatever it doesn't need to survive. And urine and fecal matter is it doesn't need, so it's going to get rid of it. And then you're going to check for instability in the pelvis too, see if there's anything moving around there. Extremities, we're going to go back to that PMS. Pulse, motor function, and sensation. Also going to put our oxygen saturation or SpO2, and then look for medical devices on bracelets there too. And then check for pupils too. Same thing, are they constricted, are they dilated? So with a pupil, the term, the mnemonic you guys will hear for it is pearl, meaning that their pupils are equal and reactive to light. So we're wanting to make sure that they are equal and reactive to light. Obtain a baseline set of vitals. We've hit on this already: pulse, respiration, skin, pupils, and blood pressure. Take note of any abnormalities, document, and then try and determine the oxygen saturation. Consider requests for ALS personnel. So follow local protocols. For our area, you do have, for both Carbon County and Sanpete County, you do have an option of a paramedic intercept that can come and help. Not all areas have an ALS option though. So like if you go down into Garfield County, or what's Monticello? Anyway, Monticello, Blanding area, you may not get a ALS response. You may just have BLS. And then consider the closest options for health facilities. And this is more in your urban areas versus rural. Depending on what your diagnosis is depending on which facility you're taking them to. So some questions for bystanders. What's the patient's name? What happened? Did you see anything else? Did the patient complain before this? Does the patient take any medication? And does the patient have any known illness or problems? On those last three questions, or the last two at least, maybe ask what's the relation to the patient. Because if it's just somebody that this is the first time that they've seen him, they may not be able to tell you his name, but they can tell you what happened, if they've seen anything else, and if he was acting weird or complaining of anything before he became unresponsive. Look for mechanism of his injuries, so MOIs, or signs that suggest a spine injury, okay? So if you get somebody that's drunk or under the influence of drugs and fall, they can have a spinal injury too. And then if needed, immobilize the patient's spine. We're just gonna walk through this. Secondary assessment of a trauma patient. You guys have any questions on the medical one of it, I hope, as we went through a lot of these, and a lot of them, we talk about the specific emergencies with medical, we'll hit on more of the assessments and what to ask with them too. Trauma patients, so they can be severe to slight, depending on what the mechanism of injury was, right? Or the location of the injury. So the serious, how we're gonna do it is look for the location of the injury on the patient. So a chest injury versus a lower arm or lower leg injury is gonna be more severe than the arm or leg. And then the patient's mental status. The other one too is we talk about mechanism of injury, a 20-foot fall versus a 3-foot fall, a 65 versus a 35-mile-an-hour injury. It's going to have very distinguishing on how serious it is too. Anytime we have an airway status that's questionable, it's a serious injury. And the same with the vital signs. If we have questionable or unsustainable vital signs that are not adequate to sustain life, it's a serious injury. And then we go back to this patient's age, right? The extremes in age, the extreme youngs versus extreme old plays a part into it. And then the big one that often gets overlooked is pre-existing conditions. Does a lady with osteoporosis in a wreck at 30 miles an hour, meaning, this is what I mean, that osteoporosis at 30 miles an hour, is she going to have some significant injuries versus a 21-year-old that's in the same car, same speed? So you got to consider some pre-existing conditions. The older lady with osteoporosis obviously is going to fare worse in those accidents in those situations. So assessment is focused on areas patient notes are painful or the mechanism of injury indicates. So that's, if they say it hurts here, we're going to go look there first. Okay. Or if the mechanism of injury was a T-bone and they were the passenger and they got hit on the right side. All right. And I want to see that right side of that patient's body to look for any signs of injuries. Determine the chief complaint, and then conduct a history of present illness to gain information on how the injury occurred. Okay, that's the same thing we've talked about, the factors, the speed, the age, the height of the fall, caliber of weapon, all of those things play a part into it. And also with that, pre-existing conditions. So the chief complaint is what the patient tells you is wrong. And remember, that can be different and oftentimes is different from the diagnosis that we come up with. Okay. But the chief complaint, the way you'll see it worded in a test question, and you may very well see that in the national and other questions, is that the chief complaint is what the patient tells you is wrong. Attain a patient history. So the nature of the force involved, we've hit on that. The direction of the force, it's like we talked the other day with T-bones versus a head-on versus a rollover too. Speed plays a definite part in that too. Your PPE was did you have a helmet on? Were you seat belted in? Was it a newer car versus an older car? All of those things too, believe it or not, the age of the car, the longer we go at this, plays a huge role on the outcome of the patient. The newer the car, the more likely the patient is to survive. As long as it's not a 90-mile-an-hour wreck type deal. Actions take to prevent or minimize the injury. It's the same thing, like the motorcycle that he had, the leathers and stuff on to prevent it. Football injuries, did you have your guards? Did you have your knee shins for soccer? All of those things that are actions that prevent or minimize the injury. And then areas of pain and injuries resulting from the accident. A lot of the times too, with car accidents or any type of accident, if they have a pre-existing condition, it's going to make it worse. I can't, that word just left me. Exacerbate, that's the word I'm looking for. Their pre-existing injury too. So that may not, that area of pain, we want to look at the area. So let's say they were, same thing where passenger hit on the right, and they have a right-sided or left-sided knee pain and all of that. Well, we may have exacerbated that, but we want to look at the right first. We'll get to that, but we want to look at the area of injuries resulting from the accident. Then we can go to other injuries. Just because it wasn't part of that injury doesn't mean it's not painful and we don't need to do something to help treat it. Perform a physical exam. So areas assessed depend on the injuries and chief complaint. It's the same thing. If they're complaining of right-sided leg pain, we've got to expose the right side. If we're complaining of back, we got to expose the back. And depends on the mechanism of injury. Then we go back to the 3 techniques. We've already hit these 2. We're going to observe, palpate, meaning we're going to feel, and then we're going to auscultate, listen for it. Observe abnormalities in symmetry, meaning one side is bigger than the other. Same with color, bruising or rashes or anything like that. Shape too. If all of a sudden his right leg's got a nice S to it and his left doesn't, then we're gonna look to see if there's something wrong there too, right? And then movement. The big one that I like to tie this into is the chest, and we'll talk about flailed chest, meaning that one part of the chest is going to come out and the other is going to go in. So you're going to see some abnormal movement. The chest shouldn't move. One part of it shouldn't move independent of the other. And it's the same thing too. The legs and all that should move should move voluntary on the patient's command. So if you're not seeing movement or seeing movement, twitching, anything like that, that's abnormal too. Palpate for abnormalities. We're going to look for shape, temperature, texture, and sensation. We've hit a lot of that already. The other thing you'll find with breaks and injuries is they tend to be, the area around them tends to be hotter, because that's the body's response to sending blood and everything it needs to those injuries to help it. Auscultate, we're going to do the decreased or absent breath sounds on these guys. I knew it could hit decap BTLS. I would memorize that mnemonic. Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. What's an abrasion? Just road rash. Yeah. That's the other term for it, the scraper or road rash. I'll leave that one up for you guys for just a second so you can write that one down. I promise you, you will see that one again. It's a huge part of your hands-on. So like the sample, OPQ or ST, decap BTLS, those are all going to be huge on your hands-on part. We've hit on this part of it too. We're going to get those vital signs early and so we can base our treatment for future assessment. And we're just assessing whether our treatment's working is what we're after. And it does provide an early snapshot of stability. That being said, if you see somebody that's having an obvious problem, just breathing or chest pain or whatever, by all means, don't waste your time with a baseline set of vitals. We've got to take that primary assessment. We've got to take care of those. And then once all of our life threats are treated, then we can come back and get that snapshot to see where we're at and where we're going forward. We're going to talk about applying cervical collars. We'll go over that too. So it's a spine immobilization device. It should be rigid and it's got to fit the patient right. And we'll talk about fitting in when we do it in class. It's a skill you guys have to pass on. Oh, the big one I will say though, that I have heard a couple of them that said, talked about removing jewelry and hair. You don't want anything metal or their hair in it, especially if you have long hair as a female, because then every time they move, it pulls hair out. And it also, if the hair shifts out, then it makes the seat collar loose again too. So do whatever you can to get rid of the hair. I've had a couple female partners that could that always carried what the heck do you call them? A scrunchie or, yeah, whatever that, and then they could hurry and grab the female's patient's hair and put it in scrunchier, and then it's easier to get out of the way. But I can't do that. So I'm the dad that does it with the vacuum and the sucks your hair up in it and then slides it over on the vacuum. Anyway, and then it's keep the patient's head in line in anatomical position. We'll go over all of that placement a bit though. Continue C-spine for these guys for a high priority. Consider ALS and then a rapid trauma assessment and complete the head to toe. This next few slides this slide will walk you through doing the rapid trauma assessment, and we're gonna check for wounds, tenderness, deformities, and crepitation. That's all hands on. So we'll hit all of that in the next few months. Consider hidden injuries, or especially if they have a distracting injury, is the other term, the hidden injury. So seatbelt injuries, airbag and steering wheel injuries, right? They're all things that have caught them and can cause injuries that way for them. Manual stabilization for the patient's head. Follow local protocols. Okay. I don't know what Carbon County has, but we can clear C-spine in the field if they meet certain requirements on North Sanpete. So when you guys get running, get a hold of the protocols. And for the purposes of the class, we don't clear C-spine. C-collar them and put them on the board. Consider requests for advanced life support. We have, as paramedics, we have a lot of different drugs, interventions. We can decompress chest, we can do IVs, we can do lots of different things that way. Familiar site, and then follow up with protocols. It's the same thing. For our area, you can call and request it. Most of the time in North Sanpete, one's paged right with every call, or one responds, whether it's not necessarily page, but we respond. And then familiar sites with the types of patient and local clinics that can help. This for me comes to the Emory Clinic over there. They actually have an ER bay. They're not necessarily a full-fledged hospital, but they can take 911 patients there if they have to and stabilize them and move them out. For us over here, we have most of our clinics won't see an ambulance. In fact, they can't, so we have to go to the hospital. Rapid trauma assessment should only take a few minutes. So I'd like to have you guys be able to be done with it too. That's my goal. As we go through the class, be able to perform a head to toe in under 2 minutes. Should be performed at the scene. And then your care or your treatment. As you guys see care, just get used to that as a treatment too. Care and treatment, same thing. So your treatment provided en route will be based on that assessment. So rapid assessment, we're going to do that. We'll teach all that. My hands all apart. I'm just going to click through these because we might actually make it through this chapter because most of this is all hands on. So some general principles: tell the patient what you're going to do, especially if there is a chance that it's going to cause them pain. Okay, we're going to feel down your arm. We're just checking to make for any injuries. We're going to feel your fingers. We're going to just talk through what you're doing to them. Expose injured area before examining it. So if they're complaining of left-sided pain, we got to have or excuse me, right leg pain, we got to expose that right leg. If they're not, sometimes you can do it over their clothing. The thing that I'll tell you to watch with is like on bikes, motorcycles, their leathers and gear, some of it won't let blood seep through. So they can be bleeding, and if they have a distracting injury and they're wearing that type of pants, they may not even know they're bleeding. So just some caution that way with it. Maintain eye contact. A lot of the times you can judge how well or how true that 10 or that 12 out of 10 pain is by their face. If they're truly hurting, you're going to see that grimace in their face really, really bad. If it's not, you're not going to see them grimace and react in their face. Apply spinal protocols, and then stop and alter assessment processes to provide care. Meaning, if you find a life threat, we're going to stop. We're going to alter our assessment. We're going to treat that right now. Now we're back into the primary assessment. We're going to treat that life threat, and then we'll come back to our secondary assessment. Head, especially on a pediatric, until they're, I want to say 6 to 12 months. I may be wrong on that, but they have those fontanelles. Remember that we talked in the class before, that's broken into 4 pieces of the skull, and when it goes through the birth canal, they kind of fold over each other to make the head smaller to go through the birthing canal, but they don't fuse and get hard until they get a little older. So we don't want to push hard on those, because you're literally pushing on their little brains. Collisions can produce head injuries. Same thing. They don't have the nice hard skull to protect their brain, so it can a collision can cause, especially whiplash, hitting a car seat hard. That's why you see the little pediatric ones that they want that baby pretty well cushioned in it around it. That's just to prevent a collision that their little head doesn't hit something. Their nose and ears, we're going to look for blood and clear fluid. The other is cerebral spinal fluid, or CFS. CSF is the term, the acronym you see for it. And then we also want to look for these little guys, they're historically a nose breather, right? For when they're nursing. So if their nose has a bunch of mucus and obstruction in it, they can't breathe very well. And also what usually mom or whatever will complain of is they're just not eating and they're fussy. Well, they're hungry, but they can't eat because they can't breathe when they nurse. So then they get fussier because they're still hungry, but they still can't breathe. Anyway, so just check that nose really well, because that's their main way of breathing. Their head, we've hit on some of this hopefully too. This isn't new news for you guys. It's larger than their body in proportion. So it increases the chance of spinal cord injury, right? If you have a 10-pound bowling ball sitting on a little 6-pound frame versus a 10-pound bowling ball on a 150-pound frame, it's the chance of damaging it's greater just because of that their spine or their head being disproportionately larger. You can't have a spinal cord injury without spinal bone fractures too. You can have some shearing and things that go on. You don't necessarily have to have a fracture there. If you, and the other reason why with them too, it's the same as, it's really hard to break a pediatric's bone, right? Because they're pliable and can move really well. If you and I, in our 30s, 40s, 50s get hit in the spine, we don't have that flexibility and movement that they do. It just breaks. These little guys that will absorb it, and then it doesn't necessarily have to break. That's why it hurts the older we get to fall. Anyway, airway, keep the infant's head in a neutral position. Keep the child's head in neutral or sniffing position. So a lot of the times to do that, we're going to have to pad underneath their shoulder, something to let their little head go back. Same thing, it's the size of it compared to everything else. Chest, we're going to look for the even breath sounds, check for asymmetry, bruising. That paradoxical movement is what I was talking about with paradox. You have a broken chest part, so when the rest of the chest goes out, it goes in. And then when the rest of the chest relaxes, it goes out. So it's paradoxical movement is what we're looking for. And then the retraction is if that you're looking at those little intercostal muscles in between the ribs to see if they're breathing with those two. Abdomen, if it's rigid or tender, distended. The same thing, it's any injury that impedes the movement of diaphragm and compromise breathing. And when we talked in CPR class, 90% or more, 95% of your pediatric patients go into cardiac failure because of respiratory failure. So if we're compromising the breathing of these little guys, we can send them into cardiac failure. Check for pelvis for stability, the pelvic girdle. So we'll talk on that. We push down and in. Extremities, we're going to look for the cap refill and distal pulse. Check for painful, swollen, and deformed injury sites. If you guys will hang tight with me, we have 12 slides to get through. So we'll probably go to line 10, but we'll get through this chapter. So the detailed physical exam, this is usually done in the back of the ambulance en route. We're going to gather any additional information, inform, and this is when we're going to call and inform the emergency department or our intercept, meaning whatever ambulance is meeting us. Get that in your guys' head now, because that's a critical fill on the physical or on the hands-on that you don't give report. So the reason why we've got it there is that we want you guys thinking, okay, we got it. What information am I going to give to the ER? So they can start their ball rolling. So just so you guys know, if you don't call in a report on the hands-on, that's a critical thing. Perform most often on trauma patients with significant injury, meaning we're going to get really detailed on it. We've checked all the life threats. We've checked the body from head to toe. Now we're going to come back and look at that injury and say, oh, see if we can determine size, bullet, amount of force, the detail as far as scarring, whatever we're looking at that way. For these patients, you will have assessed, we've hit that the entire body during the rapid trauma assessment. Now you need to assess the entire body more thoroughly to have possible signs and injuries that you may have missed. So we're going to slow down, right? We wanted the rapid trauma assessment. I want it done in under 2 minutes. This one, you're going to take 15 or 20 minutes. Look through the rest of it, see if there's anything we've missed or changed, like that last sentence. It's changed since the last time we did it. We've already hit on that first one. It's done after all of our life threats are done. All of our ABCs are completed. And that is true to that second one. If you don't get to do this because you have a critical patient and you never got past A, B's, and C's, you never even could finish your primary assessment because you were fighting an airway or you're fighting bleeding the whole time, you did not fail. If you spent the whole time just fighting your ABCs, that's all you could do, and we don't care if you get to detailed physical exam. So these guys are going to have to expose the patient, which means they're going to have to be naked. You're going to have to be trauma naked to do your detailed physical exam. Some other things we want to do is noise and motion may interfere with some procedures. So if you're on a bumpy road, some of it you may not be able to do, or you're going to have to ask the ambulance driver to stop. We're going to work around immobilization equipment, right? Once we splint or put somebody on board, we never take them off until they get cleared through X-ray. The components are similar to the rapid trauma assessment, other than with the rapid trauma, the only time we expose is if we have suspicion of injury or pain, a sign or symptom that there's an injury there. We're going to get through, I promise you, Corey. Anyway, generally does not, I'm struggling too. Generally does not need a detailed physical exam if they're not seriously injured. So this is if you have a car full of people and they were in a 15-mile-an-hour crash and there's no signs or symptoms or none of that.
we don't necessarily need to do a detailed physical exam on this. Keep an high end suspicion when in doubt, perform a detailed exam. And a lot of that goes back to the MOI. Be aware of the patient's fear and need for emotional support. That's the same thing like with a teenager. If it's a female or a male, they're not necessarily going to want an EMT of the opposite sex to be there when they have to do that, the exam of the genitals or breast or whatever it may be. And we made it. Right at 9 o'clock.
All right. You guys have any questions for me on these chapters? I know we blew through a lot of those slides, guys, but I promise you that, I mean, that's the last 3 months of our class is most of those slides. So you're gonna get a chance to do all of that, see it in detail, do it, and be able to do it with your eyes closed. If you didn't message me that you were here in class, please do so in the chat. Otherwise, you guys have a good weekend and we'll see you next Thursday.